Good evening. Welcome to tonight's Lumbar Spine Research Society educational webinar. It's a debate on DVT chemoprophylaxis after lumbar spine surgery. My name is Michael Lee, and along with Zori Boozer, we have the honor of serving as education program chairs for this year's LSRS. And we have two great speakers who will debate out this topic of chemoprophylaxis after lumbar spine surgery. The agenda is as follows. I'll give an introduction, and Dr. Grabowski will give the argument to not routinely chemoprophylax or DVT after lumbar spine surgery, whereas Dr. Andrew Dailey will give the counter argument thereafter, and then we'll have a Q&A and panel discussion. Greg Grabowski is orthopedic spine surgeon from the University of South Carolina. Andrew Dailey is a neurosurgeon from the University of Utah. We will have discussion afterwards, so please use the Q&A function in your Zoom to submit questions. We will address all questions as we can. And we're looking forward to a good discussion here. So I'd like to start off with a couple of cases. These are cases of mine. This is case number one is a 64-year-old woman, otherwise healthy, no medical issues, right-sided leg pain in the L5 distribution, failed non-op care. And you can see that she's got a grade 1 L4-5 spondylolisthesis. You can see on the MR that she's also got a bit of a synovial cyst here with the associated stenosis, and this likely accounts for her right-sided L5 pain. This is at L4-5. So she underwent MIS TLIF. You can see the inner body bone grafting here, as well as the percutaneous screws. Post-operative course, in day one, she did fairly well. No leg pain, mild back pain. The Foley was discontinued. She urinated on her own, and we're making preparations to discharge her on post-operative day 2. Post-operative day 2, she reported some thigh numbness, reported some urinary retention. She had to be straight catheterized ×2. So after that second straight cath thing with the thigh numbness, ordered an MRI. And the MRI did show a fluid collection, epidural hematoma at the surgical site. These are the sagittal views that you can see here, and more telling are the axial views where you can see the fluid collection. You know, every MRI after spine surgery probably has some form of fluid collection, but the key here is really the fecal compression. And given the urinary retention and the inner thigh numbness, decision was made to wash her out urgently, and her urinary function ultimately returned to normal. The second case is a 67-year-old woman, also healthy, left-sided L5 pain. As you can see, she too has a grade 1 L4-5 spondy, failed non-op. This is her MRI here. And she also underwent an L4-5 MIS TLIF here. You can see the bone grafting, and in this case, a cage was utilized. Post-operative course, on post-op day 1, she was doing fairly well in regard to leg pain, but she was somewhat tachycardic in the 105 to 115 range, often suggestive of post-operative pain. But on post-op day 2, her tachycardia increased to 110s to 130s. O2 sats went down as low as 89% on room air. No chest pain, no shortness of breath, but given these changes in the vitals, CT-PE was ordered. In full disclosure, this is not her CT. This is a CT of a PE, but she did have a PE. I couldn't find her actual PE. So she was treated with supportive care medically for a pulmonary embolism, ultimately recovered from this with no additional complications. So this is kind of the crux of the debate tonight, is picking our poison regarding would we rather deal with bleeding complications or thromboembolic complications? Now, obviously, there's a spectrum of both these complications. A seroma versus a DVT may not be the worst thing in the world, but ultimately what we care about are these catastrophic complications with neurological compromise or cardiopulmonary compromise or even life-threatening PEs. So to lead us in this discussion, we've got two great speakers, Greg Grabowski from the University of South Carolina, and Andrew Dailey from the University of Utah. And without further delay, Greg, why don't you share your screen and let us hear your argument. And Greg, I think you're still muted.
Thanks, Mike. I really appreciate the opportunity to be here, and thanks for everybody who's logging on tonight from home. My side argument is not worth the risks for chemoprophylaxis. I have no significant disclosures. I will start by saying that when Mike first asked me to do this, he told me that I was going to be involved in a debate. He didn't tell me that I was going to have to debate against Andrew Dailey, professor of neurosurgery from the University of Utah, head of spine surgery there. When I realized that Andrew was the person I was going to have to go up against, gosh, it really felt like a David versus Goliath sort of scenario here for me. All that being said, my hope and expectation is that we can be able to look at the data and the literature and come to reasonable conclusions regardless of who that information is coming from. So in terms of objectives, I'm going to start off by citing the published incidence of DVT, PE, and epidural hematoma. I'll review the current literature regarding DVT prophylaxis following lumbar spine surgery, and also review the current guidelines that exist in this regard. And so hopefully when we're all said and done, we end up in line with a previous historical outcome. And so I'm just going to start off by saying that not all spine surgery is created equal. And so people who have polytrauma, including spine fractures, spinal cord injury, people who have spinal deformity, people who have anterior approaches, those are people who are going to be at really high risk for developing DVT and PE. And so those, however, are not the people that Mike has asked us to talk about today. He wanted us to talk more about just our run-of-the-mill elective spine patient. And then the other piece to this is that not all patients are created equal. And so depending on a patient's age, their medical comorbidities, and their activity level, they're going to have varying degrees of risk for development of DVT and PE. And that's going to significantly impact how we should be thinking about them in terms of DVT prophylaxis and what the risk-benefit ratio is going to look like. And so as I think about the people who Mike is asking us to talk about today, and the people who are in my patient population, so I think about my University of South Carolina swimmer who I took care of a couple of years ago, a 19-year-old girl with a lumbar disc herniation who needed a lumbar microdiscectomy. Her rates of DVT and PE seemingly would be astronomically small. And I'm really going to send her home with enoxaparin. My other patient who's a 60-year-old runner with a degen spondy. So this is a guy who has no other medical comorbidities. And yes, he needs a fusion surgery, but gosh, you're going to have to hold him down to even keep him in the hospital overnight. And is he really going to be a person who's going to be at high risk for DVT and PE? And then as you kind of go up in the spectrum, people have two-level fusions, but in today's world, you can do a two-level fusion in the correctly indicated patient in a minimally invasive fashion like this with multi-level lateral interbody fusion and percutaneous screw fixation, and send them home the next day. And gosh, there are people in my town, and certainly I'm sure in all of yours as well, that are doing these at surgery centers and sending them home same day. And so those are the types of people that I think we're talking about here. And I think that that really sets the scene for what the literature ends up looking like. And so as I was thinking about this, I wanted to think back on the last 10 years and what's been my experience with this particular issue. And I for full disclosure, I'm a son of two Polish immigrants who instilled upon me the blessing and curse of significant Catholic guilt. And so if I have a major complication, I can tell you that I will tell you that those rare ones I certainly remember. And so I distinctly remember my epidural hematoma in this patient who had a pretty run-of-the-mill lumbar decompression and non-instrumented fusion. This patient was the mother of one of our geriatricians who's taken care of literally hundreds of my patients. And on post-operative day number 2, she developed bilateral perineal weakness, had this fluid collection. And ultimately, even though we washed her out, she never recovered and now wears bilateral AFOs as a result. I also distinctly remember this particular patient who had a decompression and fusion about 5 years ago and got discharged to home on post-operative day 2, only to come back with an inability to walk and significant thigh weakness, or I'm sorry, quadriceps weakness on post-operative day number 4. She was found to have this fluid collection And we washed her out and her strength returned, but she still has significant dysesthetic pain in that thigh. And so even though we were able to overcome the weakness, she's left with that. And these are the types of things that I remember. And I will tell you that I don't remember the patients that have had the DVTs and the PEs, because they often are medically managed, like Mike said, and they go on their way. And that's my own experience. And so I don't, however, think that we can go off of singular experience because these are such rare complications. And so that's where we need the literature, and we need big data in order to give us better answers. And so to that realm, if we were to look at the big data studies on the incidence of DVT and PE, and big data studies, I generally don't particularly like them, but they're great for this sort of question. So this is an NIS database looking from 2002 to 2009. And again, I'd argue that was at a time before multimodal pain management was largely in vogue. And so people probably weren't even moving as well as they are today. But this looked at over 500,000 patients having lumbar decompressions and lumbar fusions. And what they ended up finding for incidence of DVT and PE, but they're really low. So DVT and PE and lumbar decompressions respectively are 0.24% and 0.1% in those patients. And lumbar fusions are also very low. They're higher than the lumbar decompressions or bigger surgeries, but they're still really, really low, less than 1%, 0.43% for our DVT rates and 0.26% for our PE rates. And when we look at those patients, it's not even that they're evenly distributed. And so these are two charts from that article looking at both the DVT groups and the PE groups. And what they find is that uniformly, all of these patients tended to have higher rates of DVT and or PE as they got older and had more medical comorbidities. And so I think that what this starts to tell us is that indeed, just like we would have thought intuitively, there are patient-related factors that come into play here with regards to what the patient's ultimate risk of DVT and PE looks like. And so we know that there's patient-related factors. Well, what about surgery-related factors? And so this is a study looking at the incidence of DVT-PE. It's a multi-center case control study. So big numbers, but not big numbers like 500,000 sort of numbers, but still 6,000 patients. And these were patients undergoing what they were deemed to have major spine surgery. And so their rates of DVT and PE were significantly higher than the rates that I just quoted you. But part of that is because they were having bigger surgeries. And what they found is that in the biggest surgeries, the 5-segment fusions and the 4-segment fusions, the rates of DVT were significantly higher. So 3.1% and 1.8% respectively. And so just as there are significant patient-related factors, there's also significant surgery-related factors that have to do with the rates of risk when we're talking about DVT and PE. And so if we then look at the types of surgeries that we're talking about on the bigger end, incidence of DVT specifically looking at one-level fusion procedures. This is a NSQIP database study. So again, pretty big numbers. So about 5,500 patients had a 0.6% risk of DVT on that particular cohort. And so again, as you start looking at bigger surgeries, these are things that become the types of numbers that you have to consider for your potential risks regarding DVTs. And so this was a meta-analysis looking at DVTs and the various risk factors. So this is a meta-analysis looking at a series of different studies that had looked at DVT in spine surgery in general. So this is not just lumbar spine surgery, but spine surgery in general. And what they found was that they had DVT rates of about 0.7%, PE rates about 0.4%. Again, most of the time when you're looking at studies on DVTs, they tend to skew towards the higher risk patients, just because the numbers tend to be bigger and it's easier to write papers on that. And so what they ended up finding in terms of, again, specific patient-reported risk factors that led them to have higher rates of DVT: active malignancy, a history of prior DVT or PE, estrogen replacement therapy, or discharge to rehab facilities, so patients that aren't mobilizing well. And so what I would say is, gosh, I think that any of us would look at these patients and say, if you have a history of a prior DVT, I'm probably going to put you on DVT prophylaxis following your lumbar spine surgery. If you're not mobilizing at all, I'm probably going to put you on DVT prophylaxis. But do I have to routinely do that for all the people that don't fit these categories? And again, I think that what you'll find is that the argument probably should be no. And so going in the other direction, what's the incidence of epidural hematoma? So this was the largest study I could find in specifically lumbar spine surgery looking at epidural hematoma. So looked at about 15,000 patients. And what they ended up finding was an overall symptomatic incidence or overall incidence of symptomatic epidural hematoma being approximately 0.16%. And so that's a really, really small number, 1.6 per 1,000 surgeries that you do. So again, if I'm thinking about my own practice and being here for 10 years and half my surgeries that I do are cervical, half are lumbar. I do 250 surgeries a year. Gosh, having had about 2 epidural hematomas in my lumbar spine cases, it's probably about right. And so then the question is, well, the outcomes of those people, well, what ends up happening to them? And were my patients typical or atypical? And so what they ended up finding is that all of those patients, just like Mike said, end up being evacuated emergently. But despite an emergent evacuation, about 1 in 5 don't end up recovering the strength that they lose as a result of that epidural hematoma, which is the perineal weakness patient that I had. And unfortunately for Mike, his patient fell in the 4 out of 5, but not all do. And so these risks are real with anytime that we put somebody under the knife for lumbar spine surgery. And we want to make sure that that we're mitigating these risks just as much as we're mitigating those of DVT and PE. And so the other question that I think is important to raise is, where is this question coming from? And I think that probably, and by that I mean the question of, should we be routinely prophylaxing these patients? And I think that that probably comes from the comparisons to total joint arthroplasty. And I think that total joint arthroplasty often is compared to spine because they're similar patient populations. Total joint arthroplasty is a really great group of people to model after because there's only 1 or 2 surgeries that these people do, right? Total knee, total hip. And then they can very much standardize their approach to those particular surgeries, whereas it becomes a lot harder for us to do that in spine, but we can take lessons from them. And we've often done that in our history as spine surgeons. TXA is a great example of that. And so in total joint surgery, routine prophylaxis is used. And so how do the rates of DVT and PE compare in total joint surgery relative to spine surgery, where this is a place where routine prophylaxis is indicated? And this is a quote from this Current Concepts Review from 2017, and says data from prior decades suggested that without prophylaxis, the rate of DVT in patients undergoing total joint arthroplasty was between 35 and 84%. And so I'm going to read that one more time. Rate of DVT in patients undergoing total joint arthroplasty was between 35 and 84%. And so you're talking about rates of DVT that are an order of magnitude higher than our high-risk patients, and 2 orders of magnitude higher than our low-risk patients that we're discussing today. And so if you are looking at this as a model as to why to do something, well, gosh, I don't know that your risks are anywhere in the same zip code with regards to lumbar spine surgery as they are in total joint arthroplasty. So it may not be the right model. And so now we'll kind of switch gears and kind of look at some of the literature that's supporting chemoprophylaxis in spine surgery. And so this is a recent study out of Global Spine Journal in 2020. And ultimately, this was looking at fondaparinux DVT prophylaxis. And they looked at DVT, obviously, as their primary outcome. They had about 400 patients. And this particular study, I think, is really typical and kind of gives a good idea of what you normally see in these types of studies. So 400 patients. And in order to get to a place where they could be statistically significant in terms of showing a improvement with the fondaparinux, what they ended up seeing was, in order to show this, they had a 3% rate of DVT in their no prophylaxis, no DVTs in their prophylax group, and no epidural hematomas. But to get to that high rate, that 3% rate, what they did is they looked only at people who were high risk for DVT. And so they were able to power this study in their high risk DVT group in order to look at the rate of DVT and hopefully find a statistical significance. But what they did in so doing is they completely underpowered it to look at the rate of epidural hematoma. And so we wouldn't even anticipate that there would necessarily be a single epidural hematoma in only 400 lumbar spine patients if your normal rate is 0.16%. And so the other studies that I'm going to show you all look fairly similar. So this is out of Spine in 2013, low molecular weight heparin used, 367 degen spine surgeries. Of those, 241 were lumbar cases, all multi-level fusions with multiple DVT risk factors, again, to skew those numbers. They had a 3.8% DVT rate, but no epidural hematomas. But again, significantly underpowered to really give you any good literature on the rate of epidural hematoma. Here's another study that's frequently cited, literature support of chemoprophylaxis, cervical, thoracic, and lumbar cases, 2,000 patients looking at low molecular weight heparin. They had, again, out of 2,000 patients, an extraordinarily low DVT rate, 0.05%, no PEs, and they ended up having a rate of epidural hematoma of 0.4%. But literally in their title, what they end up saying is that there was not associated with increased risk of hemorrhage after spine surgery. But if you look at probably what I would say is the most reasonable data for what should be considered the baseline for rates of epidural hematoma in spine surgery, literally doubles that amount when you're looking across 2,000 patients given low molecular weight heparin. Here's another study. This one is a single institution study out of Northwestern, Journal of Neurosurgery Spine from 2017. This one actually starts to get to be in a place of having bigger numbers, about 7,000 patients. Again, they used a series of different DVT chemoprophylaxis. It was all really surgeon driven, but 2,000 patients received chemoprophylaxis, 5,000 did not. The prophylaxis group, as you would expect, had significantly more risk factors. That's why they got the prophylaxis. And so their rate ultimately was a little bit higher still than the no prophylaxis group. And what they ended up finding with regards to epidural hematomas, that they found no statistical difference in symptomatic epidural hematoma. And again, that is a true statement. However, when you look at their Kaplan-Meier type graph at the epidural hematomas and how and when they occurred, the first thing I'll point out to you is that the no chemoprophylaxis group falls in right at that 0.16% of the 5,000 patients. Again, they're starting to get to a power number that's pretty reasonable for looking at this kind of issue, and they're in line with the published data. Their chemoprophylaxis group was a lot smaller, and they started to trend above, but it wasn't statistically significant. Now, they only had, out of those 2,000 patients, 4 people that had symptomatic epidural hematomas, which is probably one more than they should have. And if they'd had one more than that, well, gosh, then they would have had a statistically significant difference on the other direction. The other thing that I would point out to you as you look at when these symptomatic epidural hematomas were occurring, the first week after surgery, the vast majority of the non-chemoprophylaxis hematomas were occurring. In the chemoprophylaxis group, which ended up seeing as a trend towards much later occurrences of those epidural hematomas, which I think at minimum raises the question of whether or not the chemoprophylaxis was playing a role in the late creation of those symptomatic epidural hematomas. And so ultimately, as you start to get into the meta-analyses and reviews, this is from the Journal of Bone and JBJS from 2010. And ultimately, they found exactly the types of things that I've just been saying, which is that risk of DVT and PE is extremely low following elective spine surgery. And ultimately, pharmacologic prophylaxis exposes patients to greater risk of epidural hematoma. And so they only end up recommending that for high-risk patients. So here's another systematic review specifically looking at the topic of epidural hematoma. This is from Spine in 2010. What they ended up finding is similar rates of symptomatic epidural hematomas in those with and without prophylaxis. But what they, again, cautioned all readers about in this regard is that all of these studies are significantly underpowered for the very rare complication of a symptomatic epidural hematoma. And so where does that really leave us? And so I think, again, Mike and Andrew and I were talking before that this still in a lot of ways can be a black box. And so I think that as surgeons, we often end up looking not only to the literature, but looking to our societies to end up giving us guidance in being able to synthesize the literature because it is so expansive in today's world. And so the good news is that we do have clinical practice guidelines, both from the chest physicians and also from NAS with regards to this particular topic. And so what do those things say? And so the chest guidelines end up saying exactly what we've just been saying here today. Obviously, major trauma patients, they put their nickel down. They say they should get pharmacologic prophylaxis. High-risk spine patients undergoing high-risk patients undergoing spine surgery. So those are people, for example, who have malignant disease and combined anterior posterior approaches. We could put any number of other things that we've already discussed here today into that category, but they put their nickel down. They said pharmacologic prophylaxis is appropriate. Spine surgery patients in general, they didn't. And they left the door open for just mechanical prophylaxis. And the reason for that is because there's really not good enough data to suggest that we should do otherwise. And the thing that I would caution you about this in particular, as you start to look at this particular recommendation, is it comes from the chest physicians. These are people who are going to care a whole lot more about whether or not a person gets a symptomatic PE than if they have a symptomatic epidural hematoma that Mike or Andrew or I are going to be washing out within 24 hours because they've got a neurologic deficit. And so I think that this is actually, even though this recommendation seems a little wishy-washy, because of where it comes from, I think it's actually pretty strongly in favor of simply using mechanical prophylaxis in low-risk patients. The NAS guidelines actually are much stronger in that regard. And so when they ask the question specifically about decreasing rate of clinically symptomatic DVT and PE following elective spine surgery, they do put their nickel down and say mechanical compression devices in the lower extremities are suggested in elective spine surgery to decrease the incidence of thromboembolic complications. And then they go further and speak specifically to the topic of chemoprophylaxis. And I think that they say it more eloquently than I can, and so I'll just go ahead and read that. The utility and safety of chemoprophylaxis following spine surgery is controversial because of the hazardous risk of symptomatic epidural hematoma. The potential consequences may confound the benefits of these agents. Most commonly performed elective spine surgeries done through a posterior approach are associated with very low risk of VTE. In this setting, chemoprophylaxis may not be warranted as it is accompanied by a definable risk of serious wound and bleeding complications. When chemoprophylaxis is used, neurologic status should be closely monitored. And so again, they are saying that for our low risk patients, the patients we are discussing today, this is not their recommendation. And so with that, in terms of conclusions, I'll say, going back to our discussion points, citing the published incidence of PE, DVT, and epidural hematoma, these are all very rare complications outside of high-risk procedures or patients. Reviewing the current literature, what I would tell you is that DVT prophylaxis following elective low-risk spine surgery, the studies that we have are largely underpowered to verify safety or efficacy in low-risk patients and procedures. They are there and they're powered from an efficacy standpoint for the high-risk procedures, but not in these low-risk patients and procedures. And then as far as reviewing the current guidelines, we have both CHEST and NAS guidelines favoring mechanical prophylaxis for low-risk patients and procedures. And so with that, I'll conclude and turn the floor over to Andrew.
Thanks so much, Greg. That was fantastic. Yeah, we'll go over to Andrew now. He'll present the countering argument.
Yeah, great, guys. Thanks so much, Greg. I think you and I will agree on one thing, and that's that certainly not all patients are the same. And I think it's one of those things where you really have to be careful about, who you're including. Unfortunately, my practice, I never quite seem to get the 19-year-old healthy swimmer or the 40-year-old runner to do, an L4-5 spondy on. And so as a result, I tend to lean a little bit more towards chemoprophylaxis for that reason. And as a result, I think you have to look at the literature fairly, cautiously here, because yes, even though venous thromboembolism is rare, there's still a number of cases, if you look at this, that are hospitalized every year. Over 600,000 people have venous thromboembolism every year and are hospitalized, and there are 50,000 deaths as a result of this. There's a high rate of VTE in orthopedic procedures. We talked about that. There's a 19-fold increase risk, and it's strongly recommended that you use chemoprophylaxis in hip and knee arthroplasty. Now, again, that's slightly different than what we're talking about. But again, a lot of these are pretty healthy, mobile patients as well. And as a result, I think, you really have to be very cautious about sort of blowing off the DVT or the PE, because as high as 10% of DVTs can result in PEs. And many PAs are asymptomatic, that's true, but 6% could be fatal. And another phenomenon that can happen is also if you have an asymptomatic PE, you're much more prone to a secondary PE, which could then be fatal. So as a result, I think you really have to, caution, yourself about missing a PE or missing a DVT. It can be a pretty costly sort of miss. Now, we'd already talked about the risk of epidural hematoma versus venous thromboembolism, and that's obviously the crux of the argument here. But we'll go through some of that literature too. And I think, again, epidural hematomas are pretty rare, and we have to really, succinctly and cautiously say, are we putting patients at more risk from a PE and a DVT than we are from an epidural hematoma? Now, we've reviewed a lot of the literature already, and we'll go through this pretty quickly. But I think, you have to understand that even though some of these big retrospective database studies say the incidence is very low, there are a lot of other studies that are more prospectively gathered where the overall incidence of PE can be anywhere up to 30%. The pooled data suggests that VTE is actually at a rate of about 2%. And this paper from Glotzbacher, again, the correlate of that epidural hematoma paper, showed various rates and showed a lower rate with compression stockings and pneumatic compression devices compared to no prophylaxis or compression stockings alone. They did, however, notice that there was the lowest incidence of VTE with chemoprophylaxis. And although they said at that time it was poor evidence, they did recommend that you use compression stockings and pneumatic compression devices as prevention measures in the majority of cases. And that's where that NAS recommendation comes from. But now look at the timing of this. Those NAS recommendations came out in 2009, and there's a lot of literature that's come out since then that can be updated. And the field has sort of moved a little bit forward, as you will, based on the chemoprophylaxis data. Now, is the rate of venous thromboembolism really as low as a fraction of 1%? And I think the answer is it depends on how rigorously you look for it. This is a paper from Japan that looked at 459 patients with various pathologies. All the patients received mechanical prophylaxis, but all also had a duplex ultrasound and lung perfusion study within 7 to 10 days. And then if a PE was suspected, they had CT venography. An overall rate of VTE was 8.3%. And even though a lot of these were asymptomatic, they did notice that there was a much higher rate in the lumbar group, that's groups 3, 4, and 5, as compared to the cervical groups, where they had rates of VTEs that were less than 3%, even if you look for them rigorously. In the lumbar group, even group 5, which was a single level lumbar fusion, had a VTE rate of about 10%. So I think depending on how rigorously you look for these things, you can really find them if you look for them. Now, Justin Hull's paper we already talked about. This is a case-controlled study of 5,700 patients, and they found the overall rate of VTE at about 1.5%. Now, they didn't look for them quite as rigorously. They only tried to match the attending's name with basically what they found in the database from either the lung perfusion studies or from the venous ultrasound studies, but they still found a significant rate of PE. Now, it was much higher again for 4 or more level fusions, but it was still almost 1% for 1 level fusions. And so as a result, you know, these are really serious complications when they do occur, and we have to prevent them. The other problem is the costs of VTE are significant. You double or more than double the length of stay, you more than double the hospital costs, and you have a 10-fold increase in mortality when you have a VTE compared to a non-VTE case. So as a result, even though we may be having to deal with an epidural hematoma in these patients, we are also, you know, increasing their mortality significantly if we allow these complications to occur. Now, this is a more recent study looking at, which is a meta-analysis, frankly, of thromboprophylaxis in spinal surgery. Is a review of 28 articles, and they only included symptomatic DVTs. They found the pooled incidence of DVT was less than 1%. The pooled incidence of PE was less than 1%. And chemoprophylaxis or no prophylaxis didn't really seem to make too much difference with the DVT. But for PEs, the rate of no prophylaxis was certainly much greater than the rate of PE in chemoprophylaxis group. And they also marked that 6% of PEs can be fatal. So you have to be very wary of the venous thromboembolism and the potential PE that may result from it. Now, we talked about a lot of risk factors for VTE, and I think, you know, these are really where we're going to. You got to understand that not everybody's a healthy 40-year-old undergoing a MIS 1-level fusion. And these are things that are borne out in the literature. You've got preoperative factors, intraoperative factors, and postoperative factors here. Obviously, older age, inherited predispositions, a BMI greater than 40, but also some will say BMI greater than 30, and a prior VTE, all put these patients at higher risk for VTE. Then, of course, the magnitude of the procedure matters, as well as does the use of steroids. Their relative risk of steroid use in a lumbar fusion surgery showed that the VTE rate increased 1.58 to a relative risk of 1.58, or approximately a 20% increase, if you will, in the VTE rate. The other things are postoperatively, immobility or neurologic deficit will also increase your VTE rates. So all those things in conjunction are important factors to understand, particularly if you're going to use chemoprophylaxis in somebody. Now, how can we intervene? Well, you know, the most common way is with heparin or low molecular weight heparin, which upregulates antithrombin 3, which then inhibits 10A and thrombin. There are also other things, but these are not studied in the spine literature, like the factor 10A inhibitors, which obviously interferes with factor 10A, warfarin, which can interfere with both the intrinsic and extrinsic component, or clotting cascades, but it's so hard to reverse that we've gone away from that. And then the mechanical compression devices, which obviously immediately break up fibrin clots. So understand where you can intervene in these patients, what the mechanism is. And so what you're looking at mostly are heparin and low molecular weight heparin when we look at these things in the literature. Now let's just talk about the epidural hematoma formation again. We talked about this, and the incidence is anywhere from 0.1 to 1% in the literature. This is that Cal study, and what it looked at was over 15,000 people. What they found was a lot of patients presented with intractable pain, most presented with decrease in muscle power. And the risk factors were a high preoperative diastolic blood pressure, gel foam usage at the time of surgery, and a high drain output. What they found is that the earlier you got to these patients, the better they did. And if you got to them within 7.4 hours, they recovered at a much higher rate than those that waited almost 20 hours before you got to them. And so as a result, if you're going to use chemoprophylaxis and you're worried about an epidural hematoma, you got to really monitor the patients very closely for any sort of neurologic issues. There's another big series from AMNO, over 3,000 patients, and they found the epidural hematoma rate to be about 0.4%. What they found was that the symptoms were slightly different when you're looking at lumbar cases versus cervical or thoracic cases. Unfortunately, in the cervical and thoracic spine, paralysis was the result of the epidural hematoma. Whereas in the lumbar spine, they found that more patients were actually presenting with sort of a sudden onset of searing pain. And as a result, if you really pick up on these signs early, you can go ahead and effectively evacuate that epidural hematoma, hopefully without neurologic sequelae. They found the risk factors, typical things you would think: multi-level surgery, plexus bleeding, high blood loss, a pre-op coagulopathy, increased age, NSAIDs, alcohol use, and a low hemoglobin. And I think, again, these are the types of patients that monitoring very closely postoperatively, if you use chemoprophylaxis, is warranted. But really, when you look at a lot of the literature, is chemoprophylaxis really increasing the epidural hematoma rate? That paper in the European Spine Journal, actually, there was no difference in the epidural hematoma positive or negative groups in the use of anticoagulants. Another paper from the group at Hopkins showed there was no association with postoperative anticoagulation and epidural hematoma formation. And then basically that same paper from Dillon, again, looking at over almost 7,000 patients, found there was no difference in the rate of epidural hematoma in the chemoprophylaxis group versus the non-chemoprophylaxis group, suggesting that you could go ahead and use chemoprophylaxis without increasing your epidural hematoma rate. Now, we all know, and we all use this, I think, in our high-risk patients. The spine fracture patients, it's been clearly shown that there's a lower rate of venous thromboembolism in patients who had early chemoprophylaxis versus those who had late chemoprophylaxis. So this is a group, not that we're talking about necessarily here, but something that we've all gone to, and we accept the complication rate. It's interesting to note that they found even in the early chemoprophylaxis group, they had no epidural hematomas, no wound hematomas, or other bleeding complications, suggesting again that you can use early chemoprophylaxis without all the complications we worry about. This is that paper from the group in NYU, 367 patients with either instrumented fusions or multi-level decompressions. 2/3 of the patients were lumbar. They started mechanical prophylaxis, obviously perioperatively, and chemoprophylaxis was started at 10 p.m. on the evening of postoperative day number 1. Even with an aggressive screening protocol, they noticed that they had decreased their rate of VTEs to 3.8%, 2.7% DVT, 1% PEs, and they used the same type of aggressive screening protocols as we previously mentioned. They also found that they had no epidural hematomas or wound hematomas, again, pointing to the fact that you can use chemoprophylaxis safely. Now, this is an article from the group at Florida. This is a retrospective study looking at a historical cohort of 941 patients versus a treatment group where they used unfractionated heparin, 5,000 units TID early on. It started immediately postoperatively. What they found is that they decreased their DVT rate from 2.7% when it just sort of was haphazard anticoagulation to 1% when they used this early unfractionated heparin protocol. They didn't really notice that big a difference in pulmonary embolism, but also significantly, they didn't really notice a significant increase in the epidural hematoma rate. Therefore, they concluded that early prophylaxis really did reduce the rate of symptomatic DVTs when it was used early. Now, this is a recent meta-analysis, and what it does is it reviews 7 articles with over 8,000 patients. And what they compared was pharmacoprophylaxis to no pharmacoprophylaxis. And what they found was the reduction, or the relative risk, was 0.42 when they used pharmacoprophylaxis versus no pharmacoprophylaxis. And you can see the forest plot down there at the bottom, suggesting clearly pharmacoprophylaxis will reduce your DVT rate. Now, they didn't find that all venous thromboembolisms, in other words, if you included PEs, the risk was not statistically significant lower, but there was certainly a trend. They did find a slight increase in the epidural hematoma rate, but they did not find it to be significant, again suggesting you can safely use pharmacoprophylaxis. But now, if you're still worried about pharmacoprophylaxis, and certainly in somebody who's low risk, you're worried about that, why not risk stratify these patients? And I think this is kind of what Greg and I have sort of come towards, and we're trying to make, a plea for sort of, a rationalization of the use or non-use of pharmacoprophylaxis in these patients. This is from the group at the University of North Carolina. What they looked at is patient-related risk factors for VTE, surgical-related risk factors for VTE, and then scored them. And you can see how they score them here. We're not going to go through the whole thing. But obviously, patients who have prior VTE, have spinal cord injury, active malignancy, are much higher risk than those patients who have no comorbidities. But you can see all the moderate risk patients in there. And if you start to think about it, I mean, we all operate on a lot of patients over 60, and certainly a lot of patients who may be smokers or who have a body mass index over 30. And as a result, you can start to have these moderate risks start to build up. And what they do is go ahead and start to add up these points. And what you do is you then subsequently at the bottom here, you can see you have a VTE prophylaxis risk benefit score. And in patients who have only 1 point, you obviously use pneumatic compression devices or compression stockings with early mobilization. Patients who have 2 points along this scale, you can use those devices, but also consider pharmacologic prophylaxis. And certainly patients who have 3 points, you want to go ahead and use pharmacoprophylaxis, likely with enoxaparin, and that's their plea. These groups subsequently went ahead and validated this in 266 patients. Now, interestingly, in a lot of their patients, they did just use mechanoprophylaxis, but over 20% did include chemoprophylaxis. They found their VTE rate was down to 0.4%. They did have a higher rate of wound hematomas in the chemoprophylaxis group, but not a higher rate of epidural hematomas. And they said it certainly wasn't greater than what was published in the literature. So they suggested looking at the potential neurologic risks, or as I mentioned back here, patient-related risks or surgical-related risks, and coming up with a risk stratification score might be a rational way to go ahead and do this. Now, one last thing before I finish up here is this is a plea, even if this amount of pharmacoprophylaxis is too much for you, I think an aggressive screening protocol for DVTs is something we really need to consider. And I'd like to make a plea for the use of the D-dimer test here. And that's something that we've used here, I think somewhat successfully, to go ahead and try to determine who's got a DVT and who needs then a pharmacologic intervention. The Wells criteria are what were traditionally used, and these remain challenging to go ahead and diagnose, by clinical methods of DVT. D-dimers, on the other hand, show a strong negative predictive value for DVTs and can be used to rule out DVTs in the outpatient settings. So what we went ahead and looked at, and it's all our neurosurgical patients, and started using a protocol of serial D-dimers. Those patients who then had an inpatient venous duplex ultrasound of either the upper or the lower extremities were looked at. And what we found is that those patients who had a positive DVT showed a significantly higher D-dimer level at the date of admission and throughout their hospital stay than those patients who didn't have a DVT. So for us, we found that a D-dimer greater than 2.5 was an independent predictor of a DVT and showed approximately a 30% increased risk from a DVT from baseline. So this is something we use to go ahead and aggressively screen these patients. So my proposed protocol would be mechanoprophylaxis with pneumatic compression devices in everybody, and then subfascial drains, certainly in the big open procedures, but also strongly considering anybody who's moderate or high risk, low molecular weight heparin at 24 to 36 hours. Now, there's still a lot of questions, the agent, the exact timing of this, and the duration for which you use it. So I'll agree that there's still a lot of questions associated with this. But I think also using that protocol in addition with aggressive screening for DVTs has lowered our DVT rate. So in conclusion, there's a low rate of VTEs in most spine procedures. Greg and I would agree on that. But there certainly are higher risk patients that we really need to consider chemoprophylaxis on. There's obviously a balance between epidural hematoma and the high cost of a VTE. But I think we've shown that actually, even in the chemoprophylaxis group, you do have a acceptable rate of epidural hematoma. And I think chemoprophylaxis will reduce the morbidity and mortality due to venous thromboembolism. So I think, in summary, I would strongly promote chemoprophylaxis, certainly in anybody who's moderate or high risk. So thank you for your time.
Great, thank you, Andrew. I'll invite Greg back onto the screen here. So please submit your questions to the Q&A function of Zoom. We have one question from Mark Smith. Aren't those patients at a higher risk for DVT, PE also often higher risk for epidural hematoma post-op, meaning the bigger surgery, higher blood loss, older age, etc. So the higher rate of epidural hematoma would be expected in that group. And that rate shouldn't be compared to the very low rate of larger studies. So it sounds like he's kind of getting at the lack of the heterogeneity of these studies in the literature, looking at larger surgeries versus smaller surgeries. And just as epidural hematoma to PE is kind of apples and oranges, are comparing those studies a little bit of apples and oranges too. Andrew?
Yeah, absolutely. I mean, there's no question about that. The epidural hematoma literature does not stratify necessarily based on sort of severity of surgery or the index of invasiveness. And I think index of invasiveness is a good thing to look at. That being said, I looked at this specifically for deformity patients in a previous webinar, and there wasn't necessarily, there's some literature to suggest that the epidural hematoma rate is not necessarily greater in the deformity literature than it is in the general literature. Now, that's not a direct apples to apples comparison, but it does suggest that maybe the epidural hematoma rate is not as great in the big thoracolumbar procedures that we do. Now, I will say one other thing. I'm not advocating for chemoprophylaxis in a big cervical decompression with a posterior instrumented fusion, because I think the risk-benefit ratio of causing an epidural hematoma there is pretty high. So that's a different category completely, obviously.
I think the other thing that to potentially consider there is that when you have a big long incision, a big long decompression, you have a lot more space for that hematoma to kind of fill out into. It's sort of like when you have a hematoma in an ACDF, because it's in such a small area. That's why it can cause such a problem so quickly, right? And cause a person to lose their airway. And so it doesn't take a lot to fill the space of a microdiscectomy, or the MIS decompression and fusion that Mike had shown. It doesn't take as much of a hematoma to create a compressive effect. And again, we're talking about symptomatic epidural hematomas, not just epidural hematomas.
Greg, I have a question for you. I appreciate that slide on Catholic guilt. I'm not Catholic, but I wonder if we as surgeons lack the proper equipoise to process these complications. So what I mean by that is I process medical complications differently than surgical complications. If I do everything right, someone has a post-op MI, sure, I feel horrible, but I feel it's a different kind of horrible than if I had a dural tear, which is kind of more on me, is that it's a reflection of my surgical skill or my ability. So of course, a lot of factors that go into an epidural hematoma, but do you think that affects our approach to picking one side or the other in this topic?
I think it absolutely does. And that's the reason I included that, because I have at least the emotional intelligence to know that it does that to me. And so, I would say that part of this concern is, if I don't prophylax these people. And again, I think that the reality of this is that Andrew and I probably do very similar things in terms of who we're prophylaxing and who we're not. But if I don't prophylax somebody and they get a DVT or a PE, that's a known risk factor, a known complication of the surgery. If I put somebody on to a chemoprophylaxis agent, then I'm increasing something. Not only am I putting them at risk for something that I can do to them, but also I'm putting them at an even higher risk of that. And so I think that there's an emotional liability that goes along with it. I think that's probably why you're less likely to see, or more likely to see people that are less willing to do that in those low risk patients.
You mentioned emotional liability. What about there's a comment in the chat about medical liability. Have you guys had any experience or thoughts on medical liability? Seems like the guidelines kind of are wishy-washy enough and kind of punt this question down to the future that I don't know if there's, well, there are no strict guidelines, but any thoughts on the medical liability aspect of this topic? Andrew?
I think we're all victims of our own practice. And as you alluded to before, when I talk to somebody preoperatively, I talk to them about the complication of potential epidural. I don't always go into much detail about blood clots and PEs. As probably I should, I always kind of generalize that as medical complications. And yes, I do worry that there is a greater risk as a result of that from getting something like a PE. I have had problems where I have had somebody who I did not know had a previous VTE, who I did not chemoprophylax and subsequently wound up with a PE and became problematic as a result of that. So that's how my literature, my points of view are skewed. And so which one is more costly from a liability standpoint? I can't prove it to you. I just know I can send patients for a hematoma more than I do for a PE.
Fair enough. Joseph Rivas had a question. I might have missed it, but do you have a statistical difference in terms of permanent morbidity, sequelae, or mortality on use of chemoprophylaxis versus non-use outside of personal experience, either opinion? If my interpretation of your presentations are correct, it seems like the data are pretty equivocal. It's hard to determine which is really superior, depending on how you sort of filter the data and sort the data. What about mechanical prophylaxis? You guys always use mechanical prophylaxis every patient for how long?
Till they're up in ambulatory, out of the hospital, basically.
You too, Greg?
I keep them in as long as they're in the hospital.
Yeah, that's just house money. I think we all ought to be doing that. What about IVC filters? You guys didn't talk much about IVC filters, and usually that's reserved for the bigger cases. But what role does that strategy play in your practice? Greg.
So I don't do that for any of my elective surgeries, even for my big deformity surgeries. I think that IVC filters, at least at our institution, have largely kind of fallen out of favor, and even the trauma guys are often fairly reluctant to place them unless it's somebody who has significant contraindications to a chemoprophylaxis.
Yeah, I'd echo Greg on that one because there are problems where you can't fish out the IVC filter. They'll get a vena cava syndrome. They'll get horrible complications from having a clot propagating off the filter. And as a result, I think you have to be very judicious when you're placing an IVC filter, maybe in a para or something like that, who you're doing some delayed surgery on, who's been in rehab for 3 or 4 weeks. Maybe that's an indication, but boy, there's nothing good in the literature there.
Interesting. And finally, do you guys get a sense that there's a divide between ortho and neuro on this topic? I mean, Andrew, you're a neuro, Greg, you're ortho. That's been kind of my observation. Andrew, what do you think? In your training, was this kind of more routine, the chemoprophylaxis? Because in the orthopedic world, it's often hammered into us to avoid chemoprophylaxis.
I was going to say the opposite, because I hate sucking out blood clots from the brain. And so, using DOACs, in patients, I just can't stand it. I mean, because there's nothing worse than somebody who's on a, fondaparinol or something like that, and comes in at 2 o'clock in the morning with a cerebellar hematoma. It's like, it's a visceral feeling. And so as a result, we're probably trained more to not use chemoprophylaxis than we are to use chemoprophylaxis.
Yeah, and I can't speak to being a neurosurgeon, but I can speak to the experience I've had with neurosurgeons. And I agree with you, Mike. I tend to think of them being a little bit more cavalier. They're the ones at our institution who push towards first 24 hours okay after trauma cases, and really pushed me in that realm. And I think that again, I don't have any reason, any data to support this, but I think that a lot of the neurosurgical colleagues, because Andrew, the types of things that you guys deal with, the horrible neurologic complications that you guys deal with all the time on the brain side, somebody who has perineal weakness or quad weakness, doesn't seem like as big of a deal, potentially.
That's a good point, Greg. That's a great point. Yeah.
All right, well, hey, I want to thank both of you guys. It's 8 o'clock Central Chicago time, so I don't want to take up too much of everyone's time this evening. Andrew, Greg, thank you for outstanding presentations. Great discussion. I also want to thank our audience for sharing part of your evening with us. Hopefully you found this beneficial. I certainly found the discussion very interesting. And we will see you all at the next one of these. Stay tuned to your email. Thank you, everyone, and good night.
Thanks, Mike.
Thank you.